So good morning. Thank you very much for the really kind invitation. This is an honor for me to be here and participating in this magnificent event. I'm going to be talking about the bronchoscopic treatment options that we have for patients with chronic bronchitis. So this is not the emphysema patients which we had just heard with lung volume reduction valves. These are more this phenotype from COPD with chronic bronchitis and a lot of cough and sputum. My conflicts of interest. And we all know what chronic bronchitis is. It's chronic cough and sputum production for at least 3 months in 2 consecutive years. What we have a lot of goblet cells, much more increase, producing mucus. We have a lot of inflammation, activation of the vagus nerve, and of course the patients have a high risk of exacerbations, which make the quality of life worse, and of course the risk of mortality increases. Characteristic of these patients is that they have in CAT score, the first 2 questions, they score really high. So we have a lot of cough and a lot of mucus. You've seen this wonderful graphic of Hartmann in the publication for 21. The treatment options that we have. At 12 o'clock, we have the chronic bronchitis epithelium. You see a lot of goblet cells. We have the balloon disobstruction as an option. A few publications, they're not really wide experience with the balloon disobstruction for chronic bronchitis. We have the bronchial rheoplasty and the cryospray, you see on the bottom. And we did have in the beginning the vagal nerve ablation, which started as a chronic bronchitis treatment, but then evolved to treatment of exacerbations in COPD. So I'm going to be talking about cryospray and rheoplasty here. Starting with the rheoplasty. What is rheoplasty? We have a catheter which delivers pulsed electrical fields. These are high-frequency fields, short duration, non-thermal electrical fields. What do? We deliver them directly on the epithelium, and our goal is to ablate the cells that produce mucus, and then cause non-necrotic epithelial and submucosal cell death. You see that we ablate from the epithelium and go deep to the cartilage with this method. Our ablating and disappearing of these cells allows the normal healthy epithelial regeneration to occur. And this happens a few days to weeks after the therapy, after the treatment. We have monopolar electrodes. This means that treatment is not available for patients with implantable cardiac devices, and we have a CE mark since 2019 for this therapy. How does the procedure work? We need 2 different bronchoscopies. We start with one side, and approximately 1 month later, we treat the second side. And we start from the periphery, from the distal, from the small airways, and move slowly back to the central airways. We want to treat as much epithelium as possible. This means overlapping manner, and this translates to about an hour procedure, 40 to 70 activations per lung. The more activations, the better the results that we have. This is our equipment. We have the generator. We have the rheoplasty catheter with the electrode, which looks like a balloon, metal balloon. We have the heart monitor, rigid or flexible intubation. We need at least 2.8 working channel minimum so that the catheter passes through, and general anesthesia. This is, as I told you, about an hour, the whole procedure. This is how it looks like. We have on the left side, you see the catheter. We insert it and click it on the bronchoscope. And you see on the bottom the balloon, which is not, you see the treatment, maybe better now. You see in the bronchi, we expand the balloon. We want circumferential contact of the balloon, and then stay there and apply the energy for a few seconds. When it's finished, you have an auditory signal that the ablation is finished in this position. You move a little bit closer, approximately, and go to the next level, and continue like this until we have all visible bronchi and segments treated. This is a clinical program from REOX, different studies all over the world. We have the first feasibility study, safety and feasibility study, and then continuing to the European registry, early feasibility studies for the US, and also the big randomized controlled trial, which completed its enrollment, but we don't have the result yet. So I don't want to go in very detail about each of them, but just give you the point of what comes out, because it's the same, actually the same or similar results for all of them. The first one, in 3 sites, Austria, Australia, and Chile, 30 patients. The inclusion criteria are important. Patients with chronic bronchitis, FEV1 between 30 and 100%. So it doesn't have to be a severe obstruction. Yeah? We have patients with at least 10 pack years. A little bit of smoking has to be there to have chronic bronchitis. And important, St. George, more than 25 points, and CAT score, more than 10 points. And as I told you, in CAT score, the first 2 questions, more than 7 points. And these are the similar inclusion criteria for all other studies. As you see here in the first one, most of the patients were Gold 2, and a few 30% Gold 3, no Gold 4 patients, and a few with Gold 1. RV doesn't have to be increased. Here it's about 140%, but it's not the hyperinflation that we are interested in. And emphysema score really low, 8%, not severe emphysema patients. Safety comes first, and these are the severe adverse events in 30 patients for procedure-related severe adverse events, all of them resolving without sequelae. So in the beginning, it looks like a safe treatment. You see in the treatment recovery period, we have 3 of 4 severe adverse events happening in the first days after the procedure. And this makes sense because we irritate the bronchi. They have these patients, we irritate them with the energy, and then most of them have a severe COPD exacerbation, experience one after the treatment. Quality of life with St. George and CAT score, significant improvement through 6 and then 12 months for these patients. And also the goblet cell hyperplasia score after 3 months in the biopsies, having almost a 40% mean reduction. This was a significant result. This means this works, goblet cells disappear, and we have the normal, not at all, not that much anymore, goblet cells. Going to the European registry, we had like a little bit more, 53 patients here. Similar inclusion criteria. The only difference was that they were a little bit more hyperinflated, so RV 165%, plus minus 40. So you see all other criteria were similar with the first one. Safety, COPD exacerbation, again, in the recovery phase and then through the 6 months. Also pneumothorax, 2 cases, and thoracic pain. What we have to consider is that these patients with a lot of mucus and this obstruction through this mucus, they are exacerbating really oft. So I don't think this is a result that surprises us. Out of these 50 patients, 8 patients having a severe respiratory exacerbation, COPD exacerbation. Quality of life, the scores also here, through the 6 months, the results really good. Improvement in St. George and CAT in both of them for the 6 months. Going to the USA study, the feasibility study, this has been a 5-year follow-up study. The 2 years results have already been published. We see here safety, primary outcome, secondary clinical benefit, the quality of life scores, and secondary outcome also the number of moderate and severe COPD exacerbations. So how can this treatment influence the severe exacerbation rate? And you see first the safety. We have 6 severe adverse events in 3 patients. Most of them happening in the first 12 months, 4 severe adverse events in 2 patients between first and second year. Most common, COPD exacerbation. So the similar results repeating. Looking at the CAT score and St. George, the first year in the red, you see significant improvement. Losing a little bit the responder rate dropping a little bit after the first year, between year 1 and 2. And this makes us ask, really, is this something, how long-term are the effects of the rheoplasty? Will be able to treat for the third or a fourth time in the future? We need the long-term data. We don't have them yet. And looking at the severe of the exacerbation, COPD exacerbation rate, you see baseline at about 1, moderate, and 0.1% severe the year before treatment, and looking 12 months after treatment at 0.7 and 0.05%, decreasing respectively, and also 12 months to 24 months staying also much lower than the year before the treatment. So this is the important message. We can decrease the exacerbation rate with everything that comes with it. The last study, the randomized controlled study in 40 US centers and 10 centers in Canada and Europe, we are still waiting for these results. Really, 270 people, patients included. We are really exciting results coming. The last study, we know mucus causes also mucus plugging, of course, and this team of Kim investigating in the States, does this mucus plugging change after this treatment? And yes, it does, as expected. We had the mucus plugging score decreased by approximately 1 segment post-treatment in these patients, and of course, quality of life, CAT scores, and GEORGE all increased. The second treatment, the metered cryospray therapy for chronic bronchitis, completely different method. So we had pulse electrical fields with rheoplasty. Here we have small metered doses which cause flash freezing. We have minus 196 degrees in the mucosa, and we use liquid nitrogen to freeze the epithelium. Our goal, again, similar with rheoplasty, cryoablate the abnormal epithelium and then causing non-necrosing death of these cells, preserving the extracellular structure and giving the chance to normal, healthy goblet cells then to re-epithelialize and repopulate and creating a normal epithelium. Reduce the chronic inflammation is a goal, and the associated, of course, airway obstruction. And you see we freeze here, but we don't go that deep. We don't go as deep as cartilage. We stay until the submucosa. And the re-epithelialization of the mucosa has been shown within 48 hours after the treatment, and also up to more than 3 months sustained. It's only under clinical investigation. It's not widely now abroad available. Here we have 3 treatments, like the thermoplasty for asthma patients. We have the right lower lobe first, then the second bronchoscopy for the left lower lobe, and the third one for both upper lobes. And we omit the middle lobe, exactly like in thermoplasty. And here is a nice video where you see the ice ring forming on the tip of the catheter, and it's the same principle. We want to cryoablate as much epithelium as possible, start from the periphery and move centrally up to the trachea. Ablate as much as possible, and you see thawing after we have the ice ring, and then it's thawing, and then we move slowly proximally until we go back to the trachea. The studies that we have so far, the lobectomy safety and histology study, one in Europe and one in Canada, with the first one direct resection within 2 hours after treatment in the European study, and in Canada study 2 to 14 days after treatment. A total of 17 patients for both studies, and we have the multi-center prospective study in 35 patients. Looking at the results, 16 subjects, primary endpoint, the device-related severe adverse event, and then the post-procedure safety, of course, and secondary endpoint here, the histology, is the treat and resect study. And what we have the primary endpoints were met in this, and we do have the histological evidence of the cryoablation with non-scarring healed tissue in the late resection group. The prospective single-arm study from the UK, Netherlands, and Canada, we have 35 patients here, feasibility, efficacy, and safety study. And you see in all quality of life questionnaires, significant improvement 6 months and 12 months after the treatment, especially CAT score, as you see, the Leicester CAF questionnaire, also up to 9 months, significant improvement. And looking to the safety, we had adverse events. All of the patients had experienced one adverse event in the follow-up phase. Most of them COPD exacerbations, and 70% of the patients had severe adverse event, all of them resolving without sequelae, in these cases, no pneumothoraxes. So it looks like it's, again, safe procedure, efficient procedure, long-term results are pending. We have here the SAM control trial from UK, 1-to-1 randomized trial. We, again, looking at the quality of life, showing between the SAM arm and the treatment arm a significant improvement in all quality of life questionnaires, and the crossover treatment showing similar results after 6 months, a significant difference. The open questions, and this is the last slide, we need long-term data. So are we going to do this once and finish, or do we have to repeat the treatment? How long do we have a benefit from this treatment? Could we add it on to patients who we want eventually to treat with valves because they are also hyperinflated? Can we combine those two? These are the questions that we have to answer in the future. So thank you very much for your attention.